Imagine a scene. You're standing in the middle of a busy emergency room. It's, chaotic, noisy, just controlled mayhem.
Right.
But then the sliding doors, they just burst open and paramedics rush a gurney past you.
Mm-hmm.
And on that gurney is a patient who is visibly, profoundly suffering. They're curled into a tight fetal ball. Sweat is literally beating on their forehead, and they're gripping their midsection, like they're trying to physically hold themselves together.
It's a scene that every emergency physician knows instantly. You can almost diagnose it from the doorway.
Really?
Yeah, there's a specific quality to the agony of the condition we're going to talk about today. It's not, a colicky coming and going pain of a stomach bug. This is relentless.
Right. The descriptions in the case studies are just terrifying. Patients describe it as a boring pain. Not boring as in dull, but...
Like a drill.
Exactly. Like a drill bit. A constant drilling sensation that starts in the upper abdomen and radiates straight through the body to the back, like being skewered.
That radiation to the back is the classic tell. And frankly, the pain is appropriate for what's happening biologically. We use the term horror story pretty loosely in medicine sometimes, but today it really fits. It does. Because the central premise of acute pancreatitis, which is our topic for this deep dive, is something that sounds like it belongs in a sci-fi thriller.
It really, really does. I was reading through the source materials, specifically the Robbins Pathology breakdown, and the realization just hits you. The pancreas, this organ that's designed to help us digest our food, it essentially suffers a psychotic break. It stops digesting the food and starts digesting itself.
Autodigestion, that's the technical term, and it's exactly what it sounds like. The body is literally consuming its own vital tissue.
So today we are going to unpack this biological betrayal. We'll look at how a vital organ turns into a ticking time bomb, identify the villains responsible, including, a specific enzyme that goes rogue, and then walk through the aftermath.
Sounds like a plan.
But before we get to the gore, we need to ground this in a definition.
We do. And the definition from Robbins is actually, believe it or not, quite optimistic, considering how violent the condition is.
Optimistic?
Yeah. Acute pancreatitis is defined as reversible pancreatic parenchymal injury with inflammation.
Yeah, I want to hang a lantern on two words there. Parenchymal and reversible. Parenchymal just means the working parts of the organ.
Exactly. The cells that actually do the job, not just the connective tissue, the functional units. The cells making the enzymes are the ones taking the hit.
And then reversible. That seems surprising. With the amount of destruction we're about to describe, blood vessels dissolving, fat turning into soap, it's hard to believe the body can come back from that.
The human body is remarkably resilient. Reversible implies that if we can stop the inciting incident, put out the fire, so to speak, the organ can heal.
It can go back to normal.
It can return to normal function. That's what distinguishes it from chronic pancreatitis, where the damage is permanent scarring. But in this acute phase, there is hope.
Okay, so we have a reversible but catastrophic injury where the organ eats itself. To understand how that happens, we need to identify the antagonist. Every good story has a villain.
In this story, the villain is an enzyme called trypsin.
Trypsin, it sounds like a generic sci-fi robot name, but this thing is dangerous.
It is the mastermind. You really can't understand pancreatitis without understanding trypsin. In a healthy body, trypsin is an incredibly powerful tool. It's a protease, so its job is to chop up proteins.
But you don't want a protein chopper loose inside the organ that is made of protein.
That's like opening a box of active chainsaws inside the chainsaw factory.
Exactly.
So biology has a solution. The pancreas creates trypsin in an inactive form called trypsinogen. Think of it like a grenade with the safety pin securely taped down.
Okay.
It's synthesized, packaged into granules, and shipped out of the cell completely inert.
A sleeper agent.
A sleeper agent is the perfect analogy. It travels down the pancreatic duct, enters the intestine, and only there does it wake up.
And what wakes it up?
There's an enzyme in the gut called enteropeptidase that pulls the pin, activating trypsin so it can digest your steak dinner.
But in acute pancreatitis, the sleeper agent wakes up too early.
It wakes up inside the factory.
Uh-huh.
And once trypsin activates inappropriately within the pancreas, it triggers a cascade. It doesn't just do damage itself, it recruits an army.
Okay.
But before we get into that molecular warfare, let's look at the crime statistics, if you will. Who is this happening to?
The epidemiology. I was surprised by how common this is. The data shows an incidence of about 10 to 20 cases per 100,000 people annually in Western countries.
Right.
It's not a rare lightning strike. It's something emergency rooms see every single week.
It's one of the most common gastrointestinal causes for hospitalization.
Right.
And while the textbooks will give you this huge laundry list of causes, a giant table of toxins, drugs, viruses, in the real world, the vast majority of cases come down to just two culprits.
The bigs two.
We call them the big two.
Biliary tract disease, which basically means gallstones, and alcoholism.
Precisely.
Yeah.
Together, they account for approximately 80% of all acute pancreatitis cases.
80%.
So if a patient is wheeled in with that drilling back pain, statistically, it's almost certainly stones or alcohol.
And I noticed there's a distinct demographic split depending on which of the big two is responsible. It's almost like two different patient profiles.
It is. If the underlying cause is alcohol, the patient is statistically much more likely to be male. The ratio is about 6-to-1, male to female.
Wow.
Which tracks with, historical data on heavy alcohol consumption.
But if the cause is gallstones, the script flips.
Completely. It becomes female predominant with a 1-to-3 male to female ratio. This is because women are statistically more prone to developing gallstones to begin with.
I want to pause on the gallstone connection because I feel like this is a source of anxiety for a lot of people.
Yeah.
Ultrasound technology is so good now that tons of people are told, hey, you have a gallstone, even if they have no symptoms. Does that mean they're all walking around with a grenade in their abdomen?
That's a very, very important distinction to make. We call it gallstone math.
Gallstone math.
While it's true that gallstones are the leading cause of pancreatitis, they're present in 35 to 60% of pancreatitis cases. The reverse is not true.
So having a stone doesn't guarantee the disease?
Not at all.
Yeah.
In fact, only about 5% of people with gallstones will ever develop acute pancreatitis.
Only 5%. Okay.
For the vast majority, the stones just sit quietly in the gallbladder. To cause pancreatitis, a stone has to do something very unlucky.
It has to move.
It has to migrate out of the gallbladder, travel down the biliary tree, and get stuck at the precise junction where the common bile duct meets the pancreatic duct. It's a mechanical accident, a plumbing blockage.
We'll get into the mechanics of that blockage in a moment, but before we leave the causes, we have to acknowledge the other 20%, the laundry list.
Right.
The Robbins source material has this table that looks like a detective's suspect board. We've got metabolic issues, drugs, infections, trauma.
It really highlights how interconnected the pancreas is with the rest of the body. Take metabolic triggers, for example. Hypercalcemia. High calcium levels in the blood can trigger it.
Right.
Or hyperlipoproteinemia.
That's high fat in the blood.
Specifically, very high triglycerides. If your blood becomes too fatty, it essentially becomes sludge.
Sludge.
And that can clog the microcirculation of the pancreas, leading to ischemia and injury.
The drug list stood out to me because some of these are incredibly common medications. I saw statins on the list. I saw azathioprine. And I noticed GLP-1 agonists and DPP-4 inhibitors.
Yeah.
Those are the Ozempics and Wegovy's of the world that are everywhere right now.
They are. And we need to be careful with context here.
Yeah.
Pancreatitis is a known, documented side effect of those medications, but it's rare.
Okay.
It's not that everyone taking them gets it, but the mechanism is there. It's just a reminder that when we manipulate metabolic pathways with drugs, the organ that manages metabolism, the pancreas, can sometimes get caught in the crossfire.
And then you have infections. Mumps. Coxsackie virus. Why mumps? I thought that was a neck thing.
Well, mumps is a virus that loves glandular tissue. It has a tropism for it.
A tropism.
That's why it swells the parotid glands in your neck, giving that hamster cheek look, and that's why it can also attack the pancreas or the testes. It's just looking for a specific type of home.
And finally, the iatrogenic category, which is a polite way of saying the doctor did it.
Unfortunately, yes. The most common scenario is during a procedure called an ERCP.
Right.
That's where a gastroenterologist passes a scope down your throat to examine the bile ducts. And to see the ducts clearly on X-ray, they have to inject a contrast dye.
And the dye causes the problem.
Sometimes the pressure of the injection or just the mechanical irritation of the instrument can irritate the pancreas enough to trigger inflammation. It's a known risk, but it's still distressing when it happens.
So we have the suspects. The big two alcohol and stones, plus this whole laundry list. Now, I want to dive deep into the mechanism. We called it a horror story earlier. Let's script out exactly how the monster gets loose. You introduced trypsin as the villain.
The trypsin disaster. That's really the core of the pathogenesis.
So normally, trypsinogen is the sleeper agent. It's supposed to wake up in the gut. But in pancreatitis, it wakes up inside the cell. What happens the moment active trypsin exists where it shouldn't?
It behaves like a commander. Trypsin is a master activator. Once a little bit of trypsin activates, it goes around the cell and cuts the safety pins off all the other zymogens, the other inactive enzymes.
It starts to riot.
It starts a riot. And these other enzymes, they have very specific targets.
Okay.
Let's introduce the lieutenants. Trypsin activates proelastase, turning it into elastase. Based on the name, what do you think that attacks?
Elastase. Elastic fibers.
Correct. And where do we rely on elastic fibers?
The walls of our blood vessels.
The walls of our blood vessels.
Oh, that sounds bad.
It's catastrophic. Elastase dissolves the structural integrity of the blood vessels inside the pancreas. This is why severe pancreatitis isn't just swollen, it's hemorrhagic.
The blood vessels literally melt.
They melt and burst.
So you have internal bleeding. Who's the next lieutenant?
Prophospholipase. Trypsin activates it into phospholipase. This enzyme attacks phospholipids, which are the main component of cell membranes, specifically fat cells.
So elastase blows up the blood vessels and phospholipase melts the fat.
Exactly. But trypsin doesn't stop with the local destruction. It turns the chaos systemic.
How does it do that?
It activates the kallikrein system, which releases bradykinins. This dilates blood vessels everywhere and makes them leaky, causing fluid to rush out of the bloodstream.
That explains the shock. The patient is losing fluid into their own tissues.
And it activates the coagulation cascade, causing tiny clots to form, and the complement system, which brings the immune system in with a sledgehammer.
It's a runaway nuclear reaction. But I want to know what pushes the button. We know alcohol and stones are the causes, but mechanically, what is the spark that wakes up that first molecule of trypsin? The sources outline 3 major theories.
Right. These are the 3 main initiating events. The first, and maybe the most intuitive, is pancreatic duct obstruction. This is the gallstone scenario.
The plumbing gets clogged.
A stone blocks the exit. But the pancreas doesn't know that. It keeps making fluid, so the pressure builds up inside the duct.
Like putting your thumb over a garden hose.
Exactly. When it's on full blast, the pressure has to go somewhere.
Right.
Eventually, that enzyme-rich fluid is forced out of the small ducts and leaks into the interstitial tissue, the space between the cells.
Okay.
Now, here's a critical detail from Robbins that often gets missed. While most enzymes are inactive zymogens, lipase is actually secreted in an active form.
Wait, so lipase is always awake?
It is. It's normally safe because it's contained in the plumbing. But when the duct leaks due to pressure, lipase is suddenly loose in the tissue. It immediately starts breaking down the local fat.
Fat necrosis.
Fat necrosis. The dying fat cells release inflammatory signals, chemical distress beacons. Those signals recruit immune cells, causing local inflammation. That local inflammation creates stress on the acinar cells, and that stress is what finally triggers the trypsin activation.
Okay, so mechanism 1 is blockage, RS pressure, leak, lipase formation, inflammation. Does trypsin. Got it. What's mechanism 2?
Mechanism 2 is primary acinar cell injury. This is where we look at triggers like alcohol, certain drugs, viruses. These agents aren't blocking a duct, they're directly poisoning the cells that make the enzymes.
How does the poison work? Is it just killing the cell?
It's subtler and more dangerous than that. It's usually via oxidative stress. The injury creates free radicals. But the critical switch here involves calcium.
Calcium keeps coming up in this text.
It's the central regulator.
Right.
Normally, the level of calcium inside these cells is kept extremely low. But toxic injury, like from alcohol metabolites, causes a massive influx of calcium into the cell.
And why does the calcium level matter to the enzymes?
Because calcium is the regulator for trypsin. Low calcium keeps trypsinogen stable and inactive. High intracellular calcium removes that stability and, well, it favors autoactivation.
So if you flood the cell with calcium, you're biochemically forcing trypsin to wake up.
You're pushing it. That's a great way to put it.
That's fascinating. So the cell gets stressed, the calcium floodgates open, and the sleeper agent activates. That leaves us with the third mechanism, defective intracellular transport.
This one is a logistics failure.
Huh?
Imagine the factory floor again.
Okay.
Usually the digestive proenzymes are put in one type of shipping crate, and the lysosomal hydrolases, the cell's waste disposal enzymes, are put in a different crate. They travel to different shipping docks. They're not supposed to meet.
Keep the explosives away from the matches.
Exactly. But in this model, there's a traffic jam inside the cell. The sorting mechanism fails. The proenzymes and the lysosomes get mixed up and end up in the same package.
Oh, no.
The lysosomal enzymes, specifically one called cathepsin B, look at the trypsinogen and say, I should cut this.
And cutting it activates it.
Yes. The cathepsin activates the trypsin inside the transport vesicle. The vesicle bursts, and now you have active trypsin spilling directly into the cell cytoplasm.
It's like a bomb going off in the mailroom. So whether it's a physical blockage creating pressure, a chemical injury flooding the cell with calcium, or a logistics error mixing the chemicals, the result is the same.
The result is the same. Trypsin activates, and the organ starts eating itself. All roads lead to intraacinar activation of trypsin.
I want to circle back to the causes for a minute, specifically the genetic and alcoholic angles, because the source material goes into some really specific biology there that helps explain why some people are more susceptible. Let's talk about hereditary pancreatitis.
This is a truly tragic aspect of the disease. We see patients, often children, who suffer from recurrent, severe attacks of pancreatitis with no apparent external cause.
No alcohol, no stones.
Nothing. It's written in their DNA.
The notes point to a few specific genes, PRSS1 and SPINK1. They sound like droids from Star Wars, but they're clearly doing something dangerous.
They are. PRSS1 is the gene that actually codes for trypsinogen itself. In hereditary pancreatitis, there's a specific mutation here that we call gain of function.
Usually gain of function sounds like getting a superpower. In biology, I assume it's rarely a good thing.
Rarely. In this case, it's a disaster. This mutation changes the structure of trypsinogen so that it becomes resistant to self-inactivation.
What does that mean?
See, normally trypsin has a built-in expiration date. It has a recognition site where it can be cleaved and turned off if it gets out of control.
A self-destruct button.
A self-destruct button, yes. The PRSS1 mutation removes the self-destruct button. So once this mutant trypsin turns on, it cannot be turned off. It just keeps chewing.
And that's a dominant trait.
It's autosomal dominant, meaning you only need one bad copy of the gene to have this super durable, dangerous enzyme.
And SPINK1.
SPINK1 is the other side of the coin. It codes for a protein whose only job is to inhibit trypsin. It's the security guard patrolling the pancreas.
Okay.
If a little bit of trypsin accidentally activates, SPINK1 jumps on it and neutralizes it.
And the mutation?
It's a loss of function. The security guard is asleep or missing entirely. So if trypsin accidentally wakes up, there's nothing to stop it.
There was a stat in the reading about PRSS1 that really stopped me in my tracks. It wasn't just about the pain of the pancreatitis.
You're referring to the cancer risk.
Yes, that number seemed impossibly high.
It is startling. Patients with PRSS1 hereditary pancreatitis have a reported 40% lifetime risk of developing pancreatic cancer.
40%, almost half.
It shows the long-term cost of inflammation, the chronic irritation, the constant cell death and regeneration. It creates a fertile ground for DNA errors and malignancy.
It really highlights why understanding the genetics is so vital for screening.
So
Now, moving from genetics to lifestyle, let's talk about alcohol again. We know it's a major cause, but the why seems complex. Why does alcohol specifically hate the pancreas?
it's a multi-pronged attack. Alcohol is a messy drug. It hits the organ from several angles. First, alcohol affects the sphincter of Oddi.
That's the valve at the end of the duct that lets the juices into the intestine.
Correct. Alcohol causes that sphincter to spasm. It clamps shut.
So it increases the pressure inside the duct, mimicking a stone blockage.
Exactly. It creates a temporary dam.
Okay, what else?
At the same time, alcohol stimulates the pancreas to secrete fluid that is incredibly rich in protein. So you have a closed door, and you have fluid that's becoming thick and sludge-like because of all the protein.
So it creates plugs.
Precisely. These protein plugs form inside the small ducts, blocking them from the inside. Then, on top of mechanical issues, alcohol metabolism creates that oxidative stress and that calcium influx we mentioned earlier.
So it clamps the exit, plugs the pipes, and poisons the cells directly.
It's a perfect storm. But here's the paradox, and it's one of the great mysteries of pancreatic pathology. Most alcoholics never develop pancreatitis.
Really? I assumed it was inevitable if you drank enough.
Not at all.
Yeah.
It usually requires years of heavy abuse, but even then, only a small percentage of heavy drinkers get it.
Mm-hmm.
This suggests that alcohol merely sensitizes the pancreas. It loads the gun. But you need a second hit, maybe a minor genetic variation, a viral infection, a dietary factor, to actually pull the trigger.
That's a crucial nuance. It's not a straight line from drink to disease. It's a complex interaction.
It is, and it explains why two people can have the same drinking habits, but only one ends up in the ER.
Let's shift gears to what this looks like in the real world. We're back in the clinic. We know the patient is in agony. How do we prove it's the pancreas? We need evidence.
We need biomarkers. When the pancreatic cells die, they burst open and dump their contents into the bloodstream. So we look for those enzymes in the blood.
All right.
The two big names are amylase and lipase.
Amylase and AMPase. These are the standard tests. But the sources suggest they aren't created equal. If you had to pick a winner, who takes the gold?
Lipase takes the gold, hands down. It's the superior test.
Why is amylase the runner-up?
Two reasons. First, amylase isn't specific to the pancreas. You can get high amylase from salivary gland issues or even gut problems like a perforated ulcer.
So it's not a reliable signal.
And second, and more importantly, amylase has a very short half-life. It rises quickly, but the kidneys clear it very fast. It disappears from the blood in 3 to 5 days.
So if a patient tries to tough it out at home for a few days before coming to the ER, their amylase might be normal by the time they arrive.
Exactly, leading to a false negative. Lipase, however, stays elevated for 8 to 14 days. It's a much more reliable witness to the crime.
So lipase is the standard. Are there other clues in the blood?
There's one finding that is very specific and, frankly, quite ominous. Hypocalcemia.
Low calcium level.
Low calcium levels.
Why does the calcium drop? Is it related to that calcium influx into the cells we talked about earlier?
Partly, but the main driver is actually that fat necrosis. Remember how lipase breaks down fat into fatty acids?
Right.
Well, free fatty acids are chemically looking to bind to something. They have a high affinity for calcium. So they grab calcium out of the tissues and the blood and bind to it, forming insoluble calcium salts.
Wait, calcium plus fatty acids? Isn't that just the chemical formula for soap?
It is literally soap. The process is called saponification.
Wow.
The patient's body is performing high school chemistry, creating calcium soaps inside the abdomen. This pulls so much calcium out of the circulation that the blood levels drop.
That is wild. And that brings us to the visuals. If a surgeon were to open up a patient with severe pancreatitis, which they try to avoid but sometimes have to, what would they see? This is where the description in Robbins gets really cinematic.
It depends on the severity. In mild cases, which we call acute interstitial pancreatitis, the organ just looks swollen and boggy. It's edematous.
Okay.
You might see small spots of fat necrosis, but the organ is structurally intact.
But in severe cases?
In acute necrotizing or hemorrhagic pancreatitis, it is a scene of devastation. The pancreas could appear red-black.
Red-black.
That's from the hemorrhage. The blood vessels have been dissolved by elastase, bleeding into the tissue, and scattered across that dark, bloody background are yellow-white, chalky deposits.
The soap.
The soap, that is the fat necrosis. And it doesn't just stay on the pancreas. Because the enzymes leak into the peritoneal cavity, you can find these chalky white spots on the omentum, the mesentery, even in the subcutaneous fat.
So the inside of the abdomen is just filled with this red-black dying tissue and white chalky deposits?
And often the cavity is filled with a brown-tinged fluid that's rich in fat globules. It's a visual representation of total enzymatic breakdown. It looks exactly as bad as the patient feels.
That paints a vivid, albeit disturbing, picture. So we've diagnosed it, we know the lipase is up, we know the soap is forming. How do we stop it? The sources mention resting the pancreas.
It's the cornerstone of treatment, and it's arguably one of the most low-tech treatments in medicine. We stop feeding the patient.
NPO, nil peros, nothing by mouth.
Exactly. The pancreas is Pavlovian. If you put food in the stomach sends hormonal signals telling the pancreas to wake up and work.
Right.
We need the pancreas to sleep. So no food, no water, nothing that stimulates the GI tract.
You essentially put the organ in timeout.
We remove the stimulus.
Yeah.
Then we have to manage the fallout. We pump the patient full of aggressive IV fluids.
Why so much fluid?
Because of the leak. The systemic inflammation makes blood vessels leaky all over the body. Fluid is rushing out of the blood and into the tissues. If you don't replace it, the patient goes into hypovolemic shock.
Their blood pressure crashes.
Their blood pressure crashes. And of course, aggressive pain management. The pain is severe, and pain itself drives stress, which isn't good for healing.
Now, we've said this is reversible and most people do go home, but we have to talk about the dangers. People do die from this.
They do. In severe cases, the mortality is significant. About 5% of severe cases die in the first week.
What kills them? Is it the pancreas itself dissolving?
Paradoxically, no. In the first week, it's rarely the pancreas that kills you. It's the systemic shock. The massive release of inflammatory cytokines, the cytokine storm, hits the other organs.
Collateral damage.
The lungs are the most common victim. Patients develop ARDS, acute respiratory distress syndrome. The lungs fill with fluid and they can't breathe. Or the kidneys fail due to the shock. The body just shuts down under the chemical assault.
And if you survive that first week,
Then the threat shifts. If you survive the shock, you have to worry about the sequelae, the complications of the debris left behind.
The sources mention
A
pseudocysts.
pseudocyst is a collection of fluid and necrotic debris. The body tries to wall off the mess. It builds a fibrous scar tissue wall around the pool of enzymes.
And it's a pseudocyst
Because it lacks a true epithelial lining. It's just a scar tissue bag.
And abscesses.
That is the big fear in the later stages. In necrotizing pancreatitis, you have all this dead tissue just sitting in the abdomen, and dead tissue is a perfect culture medium for bacteria.
Where do the bacteria come from?
The gut. The barrier between the intestine and the pancreas breaks down, and gut bacteria migrate into the dead pancreatic tissue.
And how often does that happen?
About 40 to 60% of patients with necrotizing pancreatitis will develop a secondary bacterial infection.
And once that dead tissue gets infected,
The prognosis drops drastically.
Yeah.
Now you have sepsis on top of organ failure. It requires drainage or surgical debridement, literally scooping out the dead infected tissue.
it really emphasizes how precarious the situation is. It's
Yeah.
just a cascading failure.
It is. But I want to pull us back to the start. Despite all of this, the shock, the necrosis, the soap, the surgery, the definition holds. Acute pancreatitis is reversible.
The organ can heal.
It's incredibly resilient.
Yeah.
If the patient survives the acute attack and the inflammation subsides, the edema resolves, the enzymes clear, the cells regenerate, the pancreas can return to normal function.
And here's the twist that leads into the chronic disease.
There's always a twist.
If the injury repeats, if the alcoholic continues to drink for years, if the genetic mutation keeps firing, the pancreas stops bouncing back.
It does. Evolution has limits. If the acute inflammation happens over and over, the body switches strategies. It realizes, I can't keep rebuilding this factory, so it starts repairing the damage with scar tissue instead of functional tissue.
Fibrosis.
Fibrosis. The gland hardens, it shrivels, the ducts become distorted. The hot fire of acute inflammation cools down into the cold, hard stone of chronic pancreatitis.
And chronic pancreatitis is not reversible.
No. Once that fibrosis sets in, you have a permanent loss of function. You lose the ability to digest food properly.
Malabsorption.
You lose the ability to make insulin.
Diabetes.
It's a different disease entirely, born from the ashes of the acute attacks.
It's a sobering thought. We walk around every day with these powerful chemical factories inside us, organs capable of dissolving a steak dinner in hours. And the only thing keeping that chemistry from dissolving us is this delicate balance of inhibitors and calcium levels and membrane integrity.
It's a balance we rarely think about until it tips. It's a reminder that biology isn't static. It's a constant, active maintenance of order against chaos.
A constant battle against chaos. I think that's a perfect place to leave it. Thanks for diving deep with us today.
A pleasure as always.
And to you listening, take care of your factories. We'll catch you on the next deep dive.